Thank you. Again, Melissa Stafford-Jones, California Association of Public Hospitals and Health Systems. Again, although we recognize the state's very serious budget situation, we do oppose this proposed reduction to public hospital payments. Just a couple of notes I would make about it. One is that it is a 20% fee. It's called a processing or administration fee. That is nowhere near the cost of processing or administering the program. So I do think we should call it what it is, which is a very significant cut in public hospital funding. And secondly, I do think it is important funding for supporting the services that public hospitals are providing to Medi-Cal beneficiaries, and they are also not in a position to take this kind of reduction and continue their services. The third thing I just want to note is that our understanding is that the proposed fee, in quotes, would only apply to a very specific part of the payment, the rate range IGT. I think both the analysis and the proposed trailer bill language aren't quite tight enough yet in terms of being clear about what exactly it's applying to, because it's sort of one particular piece. We actually do hundreds of millions of IGTs, and we're talking about doing many more pursuant to the last item that you just approved. So we do think, although we do oppose it, if it's going to proceed, we need to tighten up the language to make it clear. Thank you.
Right. And do you have language that, or you'll just work with?
We are working with the Department
okay,
on
great.
some language. Thank
Excellent.
you.
Thank you. Yes.
Judith Riegel with the County Health Executives Association, associating ourselves with the comments from CAPH. We are concerned about this cut.
Kelly Brooks on behalf of the California State Association of Counties. We're also opposed to the cut. Thanks.
Juliana Vorse with the Urban Counties Caucus, also strongly opposed to the cut. Thank you.
Thank you. The committee recommendation is to adopt placeholder trailer bill language and the May revision savings of $34.2 million general fund. I'll second. Roll call.
Mitchell.
Aye.
Chesbro. Jeffries. Mansour. Monning.
Aye.
That's out with a vote of 3, but again, would strongly encourage you to continue the work that you're doing with the public hospital representatives to look at their tightening of the TBL. Moving on to issue 5, managed care again, proposed trailer bill language for a 1-year lock-in.
Right now in our managed care program, our beneficiaries are able to transfer between the plans any month. And what this does is it creates additional disruption, having to work with a new plan, and the plans having to do enrollments, the state having to send out new enrollment packets, and doesn't get to fundamental goals of creating continuity of care, an ability to do care coordination, monitor the care and the utilization trends over time by one entity. So what we are proposing here, both in terms of budget savings, but a policy goal of really improving the coordination, accountability of our plans and outcomes and quality, is to ensure that beneficiaries stay with the same plan for 1 year. There are many states that have this in place. We do, I've heard a lot of feedback from stakeholders concerned about this, and it's contradictory to the 1115 waiver, and understand their concerns. Where we're coming from here is to continue the continuity of care of the provider and letting our beneficiaries stay with the same provider for 12 months during this transition, but we think it's important to work with our plans to make sure that they're managing our beneficiaries over a long period of time to ensure these quality and improved outcomes.
Adam Dorsey, Department of Finance. I'd just like to reiterate the department's comments and also just note that this is we believe this is a very critical proposal, both for budgetary reasons and to maintain continuity of care for beneficiaries.
LAO?
We don't have any issues with this proposal in concept. However, we would like to offer an alternative for the legislature to consider. They may wish to develop some sort of language that allows for an exception process for this new population of seniors and persons with disabilities. So something for the legislature to consider.
Would anybody care to respond to some of the staff comments on page 27 of the agenda, specifically with regard to the assertion by some advocates that the proposal violates federal regulations, federal Medicaid regulations?
Well, we would be we are proposing this would have to be done by a waiver to do a 12-month continuous enrollment. Many plans have that. It is true that the regulations say that we could waive it. We'd also be open, if there was interest on moving this forward, which we think it's the right thing to do, is working on the language to make it comply with different rules. It's not the beginning initial period that we're concerned, it's the continuity of care over the 12 months and the continual movement back and forth. So that's something that we would
That would be a new waiver.
Our program is pretty much, the majority of our program is under 1115 waiver, so we would be amending our existing 1115 waiver.
Got it. That's what I meant.
Yeah.
Right. It would be a new
Amendment, yes.
amendment, right. Seeing no questions from committee members, is there public comment?
Madam Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty, and we do oppose this proposal by the department. There are many reasons that Medi-Cal beneficiaries need to change plans. Their provider may change plans. Some of the plans actually have voluntarily continued to provide some of the Medi-Cal optional benefits that were eliminated 2 years ago. A Medi-Cal beneficiary may be fired by their doctor for a mental health disability or some sort of conflict. So the Medi-Cal population is not similar to the commercial population, and we don't think it's appropriate to lock them in. We are particularly concerned that the department makes this proposal on the literal eve of the enrollment of 380,000 seniors and persons with disabilities into managed care. Repeatedly during the robust stakeholder process that we had last year, the department assured us when we raised issues about continuity of care that don't worry, consumers have the ability to change plans. So now, as we're doing that, to lock them in seems disingenuous at best, and we urge the subcommittee to reject this proposal. Thank you.
Next witness.
Deborah Doctor, Disability Rights California, seconding all the things that Elizabeth said, and just wanting to bring up the it can be an issue literally of access. If a patient who's put into a plan can't get in the door or can't get the materials they need in a format they can understand, one of the assurances we were given, as Elizabeth said, was that they would be able to switch plans. And somebody can't get a medical exemption at this point on the grounds of, I can't get in the door to get services. There is no assurance in place at this point of the buildings or facilities being accessible. This is a really big issue for the folks that I represent. Thank you.
Thank you.
Chase Salinas on behalf of CalPACE. For the reasons previously stated, as they mentioned, this is a unique population, and with that, we oppose this particular proposal.
Seeing no further questions, the committee recommendation is to deny the trailer bill and propose adjustments to the Medi-Cal budget, benefits, and health care options. I'll second. Roll call.
Mitchell.
Aye.
Chesbro. Jeffries. Mansour. Monning.
Thank you very much. That's out with 3. Moving on to issue number 6, county eligibility determinations, new budgeting methodology.
As part of federal health care reform, we expect a dramatic overhaul of the eligibility rules for the Medi-Cal program as well as for the exchange and SCHIP, which will change the amount of time and resources needed for eligibility processing. The Department of Health Care Services contracts with our counties to do eligibility administration, and we pay through a county allocation process. What we're proposing here to do is to work with our county partners to redevelop this methodology so that we can be prepared come healthcare reform to have a new methodology that aligns with the amount of resources, the work, different efforts underway that need to be taken to process applications that could be based on certain rates, based on cases, based on populations, but will allow us to move away from where we are today and start over and think through what are the costs and resources needed for the eligibility processing in the future. And we've started those discussions with our county partners. Acknowledge we still need to work through some of the details on the trailer bill, but believe we're on the same page on the need to redesign the methodology.
Finance. LAO.
We support the staff recommendation to adopt placeholder language that at a minimum would require the department to provide an overview of this new methodology prior to May 2012.
Great. Any questions from committee? Public comment.
Thank you, Madam Chair and members. Kathy Sunderling with the County Welfare Directors Association. We do support the staff recommendation on this item, and we agree that the current budgeting methodology is not super transparent and could definitely use improvement. So we're looking forward to working with the state on this. We do think that healthcare reform provides a great opportunity to think about how we differentiate between different types of cases, different levels of complexity and that sort of thing, to perhaps fund those cases differently and take a look at the underlying budget methodology. So we appreciate the direction that you've provided in your action and look forward to working out the details.
Great. Thank you. Anyone else? See no one. The committee recommendation is to adopt placeholder language that at a minimum would require DHCS to provide an overview of any recommended methodology change to the legislature for its review prior to its inclusion as a budget calculation as of May 2012, as presently stated in the admin's trailer bill. I'll second that. Roll call, please.
Mitchell.
Aye.
Chesbro. Jeffries. Mansour. Monning.
Aye. That's out with 3. Thank you. Moving on to issue 7. New pharmacy reimbursement methodology.
For the last 40 years, the department has set its pharmacy pricing based on a methodology that is tied to what's called average wholesale price, AWP. Most recently, a few years ago, there was a lot of litigation related to the long-term accuracy of the AWP methodology, and as part of this litigation and the settlement, it was determined that AWP would be phased out, and would be phased out by the end of this year. Given the determination of AWP, it's necessary to develop a whole new pricing methodology. The department has always been committed to setting a pricing methodology for pharmacy where we pay as close as possible to the actual cost of the ingredients, as well as pay for the cost of the dispensing fee. There are 2 major components. To get to that appropriate cost for the ingredients, we are proposing a new methodology called an average acquisition price methodology that would be based on survey data from our actual pharmacies to get the precise ingredient costs, understand the cost of the dispensing, and be able to most appropriate align our reimbursement to the cost of doing business. There was an intent language that was enacted as part of the March budget that set forth the department's move towards the average acquisition price. We need further language to specify how we will implement this new pricing methodology. We've been working with stakeholders, in fact, had another meeting this morning. We are getting closer to a place where we can agree on what issues that they need. A big issue is around dispensing fee and long-term, knowing that the ingredient cost will change over time. There needs to be a recognition that dispensing fee should be examined and discussed over time on whether it needs to be changed. Other issues around the definitions we're working through on the definition of what would be collected as part of the survey. So we're making progress. We hope we can, through the remaining weeks, come to an agreement on the appropriate statute to move forward so that we do not end up not having a methodology in October and putting financial funds at risk.
Thank you. Finance. Finance.
Just also one thing to clarify with this. As a part of AB 97, we did enact to provide a rate reduction that included pharmacies. Our intent with the new pricing methodology is not to do another reduction, but rather as providing some sort of basis for how the existing reduction that's on the books is implemented.
Okay, thank you. LAO?
Sean Martin with the Legislative Analyst Office. No issues to raise.
Okay. Mr. Mansour.
Thank you. So this is not part of the governor's budget reduction or savings proposal. This is from Department of Healthcare Services, correct? This is initiating from them, and I guess my question is, why is this coming to a budget committee when this, to me, is clearly a policy issue? So why isn't it being discussed as a policy issue?
Good question. There are two major reasons why this is we spend billions of dollars on our pharmacy program, and without a methodology, we put all that federal funding at risk. So it's a big budget year fiscal implication if we do not have a new methodology in place, as well as the fact that the legislature and the governor took action on a 10% payment reduction. To be able to effectuate that 10%, we will need a methodology in place. And this is important to have this in place. So without this, it becomes a budget action. And this isn't the department. I mean, everything within this is an administration proposal supported by the administration that has significant budget implications.
Okay, so this is being proposed by the governor.
Everything is, yes.
Okay, I just wanted to make sure.
Yeah.
So what in this bill is going to address inflation or the rate set at a flat rate?
Well, again, we're working through, there are two pieces on any pricing methodology for pharmacy, the cost of the ingredient and the cost of dispensing. And by doing the surveys, we're going to always recognize and figure out what's the cost of the ingredient and how is it changing and being able to keep pace with it. We're also open to continuing to assess what the cost is of dispensing and be able to determine whether there's any need to bring forward to the legislature or to a change, but to have a transparent process where those two sides are discussed and that we are keeping pace with understanding where the costs are. And it would be up to determine what the changes are needed by all bodies.
Okay, is there going to be one pricing formula or multiple?
We would expect a pricing more. I mean, this is another issue that the pharmacists have brought up. There's specialty pharmacy, and there's our retail pharmacy specialty during very complex services such as blood factor. We definitely recognize that the cost of doing business for specialty is different than regular retail, and are open to looking at that.
All right, thank you.
Sure.
Public comment.
Thank you, Madam Chair. Members, Jim Gross on behalf of the California Pharmacists Association. As Mr. Douglas indicated, we met this morning, had a very productive meeting. It does come down to how you determine the ingredient cost, the mechanisms that are available to the department to do that, and then how you determine what the appropriate dispensing fee is. And as Mr. Douglas said, they're going to be performing a study. We have offered language to enhance our ability to work with them on the development of that study. There are some other nuances. The bottom line is that the legislature needs to recognize that in all probability, AAC, average acquisition cost, will save $120, $130, $140 million a year. Now, that means that money's coming out of the current reimbursement to pharmacy. And even if you think they're making money now, that's a lot of money to come out of the system. So some adjustments need to be made as a result. The average wholesale price mechanism currently recognizes that. Without that average wholesale price mechanism, you're going to need to make some adjustments, and that's where we need to work with the department and with the legislature to ensure that that occurs. Thank you very much.
Thank you.
Jennifer Snyder on behalf of the National Association of Chain Drugstores would like to reflect the same comments as Jim Gross. Fundamentally, what we're asking from the department is to look at both sides of the costs. We have pharmacies in the past have been very supportive of changing the reimbursement system to look at actual costs. We're comfortable with that in concept. It's just if you look at one side without the other, you actually will probably lose a lot of pharmacies in California to provide services to Medi-Cal patients. So that's our number one concern. Beyond that, we have had a lot of discussions with folks about really wanting to see this as a policy discussion, because the actual construct of creating an entire new reimbursement formula for pharmacies is pretty complicated. I mean, I have a whole list of what our questions and concerns are, and I will spare you from that, but it is a multitude of them. Now, with that being said, We know that the department has asked to have some type of bridge language for this year.
Right.
We would encourage the committee to, in a sense, make it bridge language, ask for them to come back next year and report what they've done in the last year, make sure that we keep track of what the department's doing. And in good faith, they're working with us. It's great to hear Toby talking about those two sides of the formula. We just want more assurances that they'll not just be considered, but they'll be acted on as well. So we would encourage the committee to stay involved, and hopefully we'll get to a resolve with the department here pretty quickly. Thank you.
Great, thank you. Next.
Peter Kellis on behalf of Walgreens. We want to echo the previous comments. A few additives to the conversation very quickly is that one of the reasons why this the community of pharmacies is so sensitive to the very complicated issue of how they're paid is the last time pharmacy reimbursement was reduced, which I believe was about 5-6 years ago. It was expected to save about $60-odd million. The actual savings that were ultimately received were twice that amount. And so that
was based on an adjustment in the methodology?
It was. And so while that could be very attractive in this budget environment, from the same perspective, from our perspective, it's very undesirable that we experience that again. So we do think that this does have merit as a policy issue. However, the negotiations that we've been part of have been very productive so far. Right. Don't know if we can close to where we need to. I think that the industry as a whole has identified standalone legislation that could be used if things fall apart, but we hope that does not happen.
Right.
So,
thank you.
Madam Chair and members, Don Gilbert representing Rite Aid. I just want to take a minute to give a little content to the dispensing fee because you've heard a lot about it. The dispensing fee right now is $7.25. The department is seeking savings, and we understand why. We get the need based on the equivalent of a 10% cut to pharmacy reimbursement. But pharmacy reimbursement, as Mr. Douglas said, comes in two parts. The ingredient, which is just an expense that we incur. It's not something that we control. And then our dispensing fee. If you were cutting the dispensing fee, which is our service, like when a doctor provider provides a service, 10%, that would be 75 cents or whatever it would be. But our cut is based on this $100 drug plus $7.25. So the impact of that, which is the basis sort of for how we backed into this $140 million, is way disproportionate beyond 10%. And so that's why we're not arguing really about that, but that's why this is such a significant issue, the dispensing fee for us. And I think, at least speaking for Rite Aid, we really, and this has always been our position since January, we really feel that it is not right to say you're going to true up one side of the formula, the AAC side, the ingredient side, but not have equal passion about truing up the other side of the formula. And Mr. Douglas has talked about it a lot more today, which we very much appreciate. But to true them up at the same time and implement them concurrently. And that last point is a really important one for Rite Aid. Thank you.
Thank you. Next witness.
Madam Chair, members, Dave Helmsen on behalf of MedImmune, Allianz Health, and long-term care pharmacies, all of which provide specialty pharmacy services to very expensive and high-risk individuals. And we're encouraged by today's discussion and Mr. Douglas's comments that they're going to differentiate specialty pharmacy. Like to see a little of that in the language. Right now it says nothing about that, but we're happy to work to get amendments together to set the department down the right trail. Thank you very much.
Thank you. Next witness.
Madam Chair and members, John Valencia representing a variety of pharmaceutical manufacturers. I want to comment on another implication of this issue. Sometimes it's not obvious that a single issue has fairly significant two-for implications. Sure. This one does. And it relates to your still open vote-only item number 6, where you have to have made an adjustment on anticipated revenue based on the provider cut that was enacted previously. Now you're talking about a formulaic adjustment. I think I understood finance to say, however, that'll come within the increment of 10% and constitute part of that, correct? You're not adding a reduced provider reimbursement rate and then 10% still below that off the bottom.
Right. So the intent of this proposal isn't to go beyond what was already enacted.
Understood.
Right.
Yeah. 21 years ago, the pharmaceutical manufacturing industry, together with the legislature, joined with the administration to develop a drug rebate program. And I do want to address one technical error in the analysis, and I hesitate to describe it that way. It's a fairly difficult area. Rebates are, in fact, pegged to what you pay pharmacy. So as you've made this adjustment in item 6, as you continue to adjust pharmacy reimbursement and take money out of the system going out of the system to pharmacy, you'll also have to account for reduced revenue coming back to you. Drug utilization will remain fairly constant in certain categories, no doubt. Cardiovasculars, respiratory products, and so on down the line. But as you adjust, the key element that finds its way into our contracts with the department, you have to anticipate that that's one more factor that's going to adjust revenue. It's that, purely. I'm here just to make a technical comment because this is a two-for implication that really calls for policy analysis in an area that probably hasn't been examined for quite a while. Thank you.
Thank you very much. Yes,
Well,
sir.
just to respond to John's point, which is an important one. You know, part of the pharmacy world has always been very complicated, and sometimes you probably hear it over the years that why do we always offer brand drugs rather than generic? Well, part of getting the average acquisition cost deals with this issue. We do brand because we get such great rebates.
Right.
But to be able to get to a pricing methodology that really gets to cost, then we can determine what's the most cost-effective approach. We might lose some of the rebates, but we're able to still overall get the most cost-effective price because we're going to the cost of the actual drug. So it's not that what John is saying is wrong, but it's just about how do we get to the most rational approach to pricing as well as delivering care.
Okay. Seeing no further comment, the committee's recommendation on this issue is to adopt placeholder trailer bill to develop a transition methodology. Roll call.
Mitchell.
Mitchell, aye.
Chesbro. Jeffries. Mansour. Monning.
That's out with 3. Moving on to issue 8, extension of sunset date for AB 1629 quality assurance fees and expansion of fee to pediatric subacute care facilities.
Several years ago, the legislature and the previous administration dramatically overhauled the rate-setting methodology for our nursing facilities to move them from a methodology where all facilities were paid the same rate to a facility-specific rate methodology that was driven by rewarding facilities that invested in labor and trying to improve the quality of care in the facilities. Part of this new methodology was funded by a quality assurance fee assessed on the nursing facilities of 5.5% to 6%. That helped reduce the general fund impact of moving to this new methodology. And this new methodology has been reauthorized over the years, and most recently last year, the previous administration and the legislature enacted a 2-year extension and really moved to continue the focus on quality by including a quality and accountability component to the rate-setting methodology, where a component of the rate would be paid based on facilities meeting certain outcome measures, whether it was labor staffing rates to family and patient satisfaction, as well as quality indicators. Most recently, we just enacted, the legislature and the governor, a 10% payment reduction that will now take the rates in the budget year down by 10% from based on the 2.4% increase the facilities were supposed to receive. We are now coming forward with a proposal to extend 1629 an additional year, because without extending the methodology, we are at risk of losing $500 million in revenue from the quality assurance fee. That will have implications on the general fund and the ability to continue to fund this nursing facility methodology, as well as other services within the Medi-Cal program and social services. So to extend it, we also need to make sure this works for our facilities, and therefore we are rescinding the 10% payment reduction in the budget year +1, as well as giving them back money that they lost based on the 10% payment reduction in budget year. We acknowledge this is a lot of general fund increase, but it is offset by the additional revenue that overall is a benefit to the state. And we are also will be delaying the implementation of the quality accountability payment 1% until the subsequent year, given the 10% payment reduction in the budget year. We're also proposing to expand the quality assurance fee to pediatric subacute facilities to reduce the size of the 10% payment reduction. We have heard back from some of the stakeholders' concerns about the pediatric subacutes. We're willing to work to see if it is the right thing. We wanted to do it as a way to reduce the impact, and it's determined that overall it's not workable. We are open to discussing that. So that is the proposal. Thank you.
Finance.
I'd like to acknowledge the hard work that the department has done to come to the agreement that you see before you as the proposal here, and we believe that this is probably the best deal that we think we can get on this issue at this time.
LAL.
We have no issues to raise.
Public comment?
Deborah Doctor from Disability Rights California, speaking in opposition to this proposal, as I have spoken in opposition to similar proposals every year since AB 1629 was passed. I have a little bit different view of it than Toby, and I think I'm correct in saying what this means is that unlike other long-term care programs who serve the same population, the net effect will be that the nursing homes will be getting an increase where others have been cut or eliminated. In the case of adult day health centers, they've been eliminated. So when the 10% reduction gets rebated, that means the nursing homes will have gotten a 2.4% increase when other programs have been cut or eliminated. I don't think that there seems to be a portrayal of the quality assurance fee as something somehow that the industry is doing as a sacrifice, but I don't see it that way at all, since they recoup the quality assurance fee either in the rate in the case of publicly paid residents, or they can recoup it from private pay residents by raising the rates. But they have been able to use it as kind of a magical shield to say, if you don't protect us from the cuts, we might not support the continuation of the fee. The fee is good for them. So making public policy here on the basis that somehow the quality assurance fee is a bad thing for the industry and they're doing us a big favor by having it, I think would be a misinterpretation of how it's actually worked. The fee has never brought in enough to cover the annual increases. We're paying about $1 billion more a year now than we were before AB 1629. It does not all come from the quality assurance fee and the federal match. A big chunk of it comes from the general fund. So I guess what we're saying here is next year, regardless of the fiscal condition of the state of California, we're going to have enough money to give this industry $400 million back, but we don't have money to continue adult day health centers, and we're cutting IHSS. And I think that sends a message that flies in the face of, among other things, the Americans with Disabilities Act and the Olmstead decision. It says, we have money for long-term care, but we're favoring institutions in how we spend it. We're cutting community programs and we're favoring institutions. And it doesn't have to be that way. And this is too big a decision. And as you said before, there are things that are policy decisions that should be made in policy committees. And I think this is one of them. This is a funding system that has worked well for the industry, has not worked out so well for the residents of the state of California. The increase in quality of care has not been in proportion to the $1 billion more a year being spent on that care. So I respectfully ask you to reject the administration's proposal. Thank you.
Thank you for your testimony. Next, public comment.
Hi, I'm Brandy Wolf with SEIU, United Long-Term Care Workers, representing over 300,000 long-term care workers, of which 10,000 are nursing home workers in support of the staff recommendation. The proposed May revised trailer bill language is a dramatic departure from last year's budget language that created the quality assurance fee or quality assurance system for facilities. The current language treats all facilities the same, despite the fact that some facilities have been diligent in their efforts to improve patient care and worker retention, while other facilities have failed to even try. SEIU welcomes the opportunity to work with the committee and with the department to improve the proposal. So again, we support the staff's recommendation.
Thank you.
Mr. Chairman and members, Barbara Glazer with the California Hospital Association. We represent some of the hospital-based pediatric subacute care units that would be brought under the fee, which is new for them. We're looking at the proposal, talking to our members, and we'll be working with the department. We don't have a position on it yet, but we're reviewing it.
Thank you.
Mr. Chair, members, Dave Helmsen on behalf of the California Association of Health Facilities. This isn't our approach to solving this problem, and we are the people that do pay the tax that we put on ourselves years ago when 20% of the industry was in bankruptcy, and we're struggling to take care of the patients that the system sends us, which arguably are the most costly and complex individuals in that same population. I guess by same population we mean everybody that's old. But nonetheless, if you believe that home and community-based care works, which we do and have never not supported an increase for those folks, but you have to know then that they call out those patients that can and do have supports in the system. Those that don't, or those that have reached a point of in the course of their treatment that can no longer be at home or in the community, end up in our facilities. This fee was adopted as a way to help leverage federal money to help us care for those patients. And the money that would be, quote, coming back to the facilities is either money they paid in fees or money that was generated directly from those fees from the federal government. So we think there's some work to be done on this proposal. It's very complicated, and it is a departure from what we've seen. But we do believe it keeps in place the initiatives and the directions headed towards better quality and towards program improvements that have been done over the years, last 4 or 5 years, in the concept of this methodology. So we will work with it. It's going to be an imposition, at least in terms of cash flow and as well as operational difficulties for facilities. But we don't see a better option on the table right now, and would like to think we can work through this with the department. Thanks.
Thank you. Any other public comment? Seeing none. Committee questions, comments? Seeing none. The chair's recommendation is to approve the sunset extension and expansion of the fee and adopt placeholder trailer bill language to continue discussions with all stakeholders. I'll make that motion. Is there a second?
I'll second.
So motion and a second. Clerk will call the roll.
Mitchell, Chesbro, Jeffries, Mansour, Monning.
Aye.
Has to.
Thank you. We'll now move to issue number 9, federally mandated HIPAA updates and system compliance.
The department is responsible for ensuring its compliance with the Health Insurance Portability and Accountability Act, commonly known as HIPAA, for our 7.5 million Medi-Cal beneficiaries, as well as the services we provide. This means that we are always having to work on code transaction updates, on privacy and security, on preventing breaches. There's a lot of work that continues to go on with our ongoing workload. And then with healthcare reform, there were new requirements instituted for HIPAA. So we are requesting approval of both existing and new resources to make sure that we comply with all the HIPAA requirements that are in existence and will be added over the coming years.
Finance?
Alicia Alvarado, Technology Agency. We have no issues.
Okay, great. Thank you. LAL.
Ross Brown with the Legislative Analyst's Office. We would just like to note that the Senate only approved the May revised requests and did not approve the request for 3 positions from the January budget.
Got it. Public comment? Any questions from committee? And so the recommendation coming out of committee is approval of May revised and the January proposal. second? Roll call.
Mitchell,
Aye.
Chesbro, Jeffries, Mansour, Monning.
It's out with 3. Issue 10, California Medical Assistance Commission, the CMAQ elimination.
Since 1983, the Department of Healthcare Services and its Medi-Cal program has worked with the California Medical Assistance Commission to ensure access to inpatient hospital services for Medi-Cal beneficiaries, ensuring the most cost-effective rate for the program. And this has been done through what's called a selective provider contracting program, where we contract with certain hospitals to get the best rate for the state, but guarantee these hospitals that they receive a certain volume of Medi-Cal beneficiaries. What we've seen with the hospital industry and changes in the marketplace, that the selective provider contracting program has not been as effective as it was in previous years, and that there's a need to move to a new payment methodology, which the legislature and the previous administration enacted last year based on diagnostic-related groups, or a bundled payment system that guarantees more control over the length of stay and the payment from a hospital perspective to create administrative efficiencies, and from the state that we can control the overall costs and spending on inpatient over time. Moving to this payment methodology means that the need for the CMAQ Commission is no longer needed, and we're proposing to eliminate the CMAQ Commission as we implement the new diagnostic-related group system, and we would move those staff over to the department, bringing them in. They would have new roles, but we would want to make sure that every staff continue to have a job, and we maximize their expertise and staffing within the new department, but there would not be the need for the commission.
Before we move on, would you address the questions in the agenda?
Oh, I'm sorry.
Could you please provide an explanation of the proposed timing of the implementation of the DRG system and elimination of CMAQ?
So right now we're working on implementing this new DRG-based system. We have we're working with the California Hospital Association. There's both a work group that brings together all the hospitals externally. We have a contractor on board who's working through that. It's going to take time. We expect we will have that methodology in place by July of July of 2012. We're therefore requesting at that point to be eliminating the commission. Now, if it turns out that the DRG methodology isn't in place, the way we've structured the statute is that we would still continue to have the selective provider contracting program in place. We would have that contracting authority, but rather than it be done under the commission responsibility, it would be done under the Department of Healthcare Services responsibility. So we fully intend that we're not going to get rid of the program until we have a replacement program, but the role of the commission, we believe, can end at the end of the budget year.
Got it. Finance?
Robert Nelson, Department of Finance. I do want to note that we appreciate the great work done by CMAQ, but given the move to the DRG system, we support this proposal. I also want to note that the budget savings will actually be in budget year +1.
Got you. Thank you. LAO?
Sean Martin with the Ledge Analyst's Office. We don't have any issues with this proposal.
Thank you. Any public comment?
No, this is Denise DeTrano from the California Medical Assistance Commission. We also, I have to agree with Toby when his comments about the program probably has run its course, both not only in the way that hospitals are financed through the SBCP program, but also the hospitals, how they're being contributed over the years for the non-SBCP program. I would like to say that we'd like to see the two events coincide, that the DRG implementation and the elimination of CMAQ be coincided together within the same time period.
Got it. Fair enough. Questions from committee? Seeing none, we'll adopt the May revise and placeholder trailer bill language for implementation. So moved. Roll call, please.
Mitchell?
Aye.
Chesbro? Jeffries? Mansour? Monning?
Thank you. That's out with 5. Issue 11, Healthcare Reform Resources Request.
As part of the Affordable Care Act, clearly there were big dramatic overhauls on coverage expansion, as well as the development of the exchange eligibility system changes. But there were also many other changes in the Affordable Care Act that are going to impact the Medi-Cal program and our operation. And what we're requesting is resources to implement some of those other changes, including a lot of increase in program integrity requirements on provider enrollment, a lot of work on dual eligibles, and work on integrating the benefits on the Medicare and the Medicaid side that will really enhance coordination as well as cost savings. This includes expanding the PACE program. And then there's a lot of system changes where the state Medi-Cal program has to align with the Medicare fee-for-service program, and we need resources to do that, both in terms of rates and benefit rules. So we're requesting resources to do that.
Mr. Jeffries.
Who is we that's requesting this?
Well, when
it actually doesn't say on here who is actually requesting the.
Well, these are the administration is requesting the resources for the Department of Health Care Services.
How many employees does that department currently have?
We have 3,000 employees, with a vacancy rate of approximately 20%. But we have, I'd be happy to spend some time talking about all the different activities that we have to do in the department. And these are new activities that we can't take on with the existing resources.
So out of
3,000
employees, there isn't anybody in there who could help take on some of these duties and allow us to use $495,000 in general fund for something else that might actually make a difference to somebody's life out there.
We're always looking for ways that we can be as administratively efficient. We have a $42 billion program. When you look at the admin of our program compared to what we spend as a payer, and you compare that to health plans or others, it's extremely low. We're trying to use our dollars and our staff resources as cost efficient as possible.
And I don't necessarily argue with that. I think the optics are pretty bad, though, to have the staffing that you do of 3,000 and then have the cuts that we're implementing, especially my colleagues across the aisle making incredibly difficult cuts, and then to turn around and ask for nearly $500,000 in more employees when these cuts are being implemented. I think the optics of that are pretty bad, so I'd encourage you to reconsider.
Finance.
Robert Nelson, Department of Finance. We support this proposal. Workload's justified to accommodate healthcare reform.
Leo? Any public comment? Thank you. The committee's recommendation is that we adopt the May revised proposal. So moved.
Second.
Roll call.
Mitchell?
Aye.
Chesbro? Jeffries?
No.
Mansour? No. Monning?
Aye.
That's out with 3. Our final issue for the day is issue 12. Are you happy? I know you
Very
are.
happy.
Transition of community mental health to Department of Health Care Services. Mr. Jeffries, if we look back on the agenda just today, we've transferred a whole lot of work over there to the poor Department of Health Care Services for those 3,000 people. They're going to be busy next year if they haven't been so far.
This proposal, the administration's proposal, is to do further consolidation, really the governor's commitment to looking at administrative efficiencies and consolidating departments. So that's one goal, but I would say as a department, as well as the governor, this is also the goal of really integrating functions, both in terms of improving the health. Our department is about preserving and improving the health, and mental health and health are interconnected. So this is a way to drive forward both better health care policy, Medicaid financing, and the outcomes for the population, as well as using our finite administrative dollars as efficiently as possible, bringing it all under one department. So we expect fully that this will be a good thing for the mental health community. There is no intention of minimizing the important role of mental health. It will have an important role within the Department of Health Care Services, but it's a way that we can more efficiently run the program and maximize the outcomes of the programs.
I'm Mark Heilman from the Department of Mental Health, and I'd like to echo Toby's comments. We see that this proposal provides opportunities to streamline government and realize some efficiencies and economies of scale. But as Toby's indicated, one of the important issues that we need to keep in mind as we discuss this proposal is that we need to ensure the continued prominence of mental health issues and substance abuse issues as the transition to the Department of Health Care Services is discussed.
Finance.
No further comment. We just think this is a good opportunity, as we're looking at a lot of different things with different departments right now to combine some important functions together.
And LAO?
Sean Martin with the Ledge Analyst Office. As I testified at yesterday's hearing, we believe the proposal has merit, but the details are lacking. And if it pleases the chair, I'm not going to reiterate my testimony from yesterday. With regards to the budget bill language that they're proposing, we're recommending that you reject it. We think it gives the department too broad authority. However, if you do want to adopt some budget bill language to do this, we'd recommend at least a 45-day notification period in order to give the legislature an opportunity to review the shift.
Thank you very much. Oh, yes.
In regards to budget bill language, we're flexible. We just want to make sure that as the functions move over to the Department of Healthcare Services, they have the necessary resources to make it a successful transition.
Okay. Any public comment?
Stephanie Bray, I'm with SEIU Local 1000. I was here yesterday. We talked a little bit about this. I just wanted to be clear. The sergeant's passing out is a letter from the employees at Mental Health. We are here talking about alcohol and drug programs, and Mr. Mibb also. We represent employees at those departments too. But mental health is especially impacted because, because they're currently in the process of the layoff process also, but there's a lot more employees at Department of Mental Health. And they're not saying they're opposed to this process. They're just saying they want a clear and transparent process. They currently are very frustrated with the current process right now. They are being told a variety of different things. One of our members who was here earlier, but he had to go back to work, was in a meeting this morning where he was told that his division would be, the decision on who would go to Department of Health Care Services was decided on a 10-month-old survey where nobody asked, the survey did not ask about anybody's actual job duties, and that's how they would decide who went to Health Care Services. That was his division. It's different in every different division. The employees just want to know how the decisions are being made. Nobody has told them there's no clear plan. We're asking you to just require the department to tell you how they're going to be making these decisions and have a clear plan. The employees are not opposed to it. They just want to know what's happening. And that's what the letter says. That's what the employees, that was just this morning. Those are the signatures we could gather this morning. Mental Health has talked about their great, how they have a plan, and how they've done this great job of this lovely org chart. One of our members who is a research analyst too, because of this lovely org chart, he and all the layoffs, he now reports to Kathy Gaither, the chief deputy in the department, because everybody above him has been laid off. So he now reports to the chief deputy director. So I think they need to spend a little bit more time and do a little bit more planning, and I think you should be involved in that process.
Well, thank you very much, and we welcome the input from the employees along the way in this process. So, thanks. Yes.
Mr. Chair and members, Pat Ryan with the California Mental Health Directors Association. We support the transition from DMH to DHCS of the Medi-Cal Specialty Mental Health Program. We actually proposed something to this effect earlier in the year because we believe that it will lead to more efficiencies in the Medi-Cal Specialty Mental Health Program. It's been pretty confusing and chaotic over the past couple of years, trying to figure out who has responsibility for what in policy and claims processing and things like that. County mental health departments manage the Medi-Cal specialty mental health program. They provide the certified public expenditure. We need to have a very professional business relationship with our state government in managing this program. We have had a really good relationship with the Department of Healthcare Services over the past couple of years, developing a good business professional relationship, which is one of the reasons we thought it would be a good idea to transfer that. But we also agree that it has to be done in a thoughtful way, and right now I think it is pretty chaotic at the Department of Mental Health. It's been difficult for us for a while to figure out who's doing what and what stays and what goes. We agree with the legislative analyst's points. We think that the authority that is being asked for in the budget trailer bill language is pretty broad, and as you've heard in other hearings from the mental health community, people are pretty confused and concerned about where all of mental health is going to go besides the Medi-Cal specialty mental health program, and whether or not that's all going to transition to DHCS, and does this language give them the authority to do that without a thoughtful policy discussion and stakeholder input? The final thing I want to say is that DHCS traditionally or historically has not focused on mental health and behavioral health issues very much. I think that's improved over the last couple of years. I think that this is also an opportunity to improve that and to ensure that we see individuals' health, both mental health and physical health, as being part of one person. And I think that we can do a better job of integrating care between people's mental health needs and physical health care needs. So I think there's a lot of opportunity with health care reform to do it better and to do it right and to actually improve the health outcomes of the people we serve. So we see this with, as a good opportunity. How we do it and how thoughtful we make the process and how open the process is important to our community.
Thank you very much, Matt. Any other public comments? Well, clearly considerable additional discourse needs to take place with the mental health advocates, the mental health system providers, county mental health plans, various interest groups, including the employees, and also with the legislature needs to occur before this can proceed. It's anticipated these discussions will be ongoing through the course of 2011-12. The chair's recommendation is to hold this item for further consideration and legislative oversight. I don't believe that requires a motion, does it? No. Nope. So that's where we are at this. Yes, I'm sorry. I should have asked for committee comments. Yes.
We did cover some of this ground yesterday. I just want to underscore my ongoing concern about how we position mental health within DHCS. I think a lot of the realignment offers opportunities for better integration at the community level. The last comment about the importance, we tend to segregate into these silos different aspects of health care, sometimes called body part medicine. I think part of the opportunity of health care reform is a more integrated approach to health care, including mental health care. And just hope in our further deliberations that that can be paramount in our thinking. But I want to thank the panel members for your hard work and getting us to this point, and look forward to continuing to work with you.
I agree with everything that you said, Mr. Monning. Flip side of that coin, though, too, is to make sure that the unique needs of persons with mental illness and their families don't get lost in a larger world of healthcare. So we've got to figure out that balance between keeping the distinct focus that's important on the one hand, on the other hand, creating the integration that you're talking about. So that's part of the challenge. So that being said, this completes our discussion for the day. I'm not going to close down yet because I have to add on to, and any other member who may have missed a vote can add on to votes along the way if they choose. So I don't know if we need to do that on mic or can I just, yeah, okay. So that completes the discussion. Thank you all very much.